Thank you. Dear colleagues, let me share you as a consequence of the first presentation to share with you the latest innovation in cancer-related treatment. Personalized and Precision Medicine, PPM, has a unique and promising potential to offer an alternative approach to cancer treatment, including canonical cancer patients and the pre-cancer persons at risk, being focused on tailoring medication to individualized specific genetic, biochemical, and lifestyle factors. But just look at major causes behind the genetic changes specific for cancer. It's just the overview. PPM allows for the creation of focused diagnostic and predictive tools, as well as multi-targeted medicines that address specific gene mutations by leveraging knowledge about cancer, including its genetic makeup. PPM has revolutionized cancer diagnostic and treatment by enabling highly individualized therapeutic strategies based on an individual's genetic, molecular, and environmental characteristics. Advances in omics profiling, genotyping, and biomarker-driven approaches have enhanced diagnostic accuracy and optimized treatment selection. Just look, it's just the overview. It's a biomarker-driven omics profiling in PPO guided clinical practice. In general, tumor omics and biomarkers are increasingly becoming critical parts of routine clinical care for patients with many cancer types. Look, just overview, biomarkers in cancer care. In particular, the latest is imaging. And thus, biomarker-guided molecular profiling is increasingly being used to guide cancer patient care, especially in advanced and incurable cancers. Commonly known, for example, genetic biomarkers include, look, very well known, you're just familiar. Its spectrum of actionable mutations in lung carcinomas, colorectal cancer, and skin melanomas, just an example. Specific biomarker subsets for lung adenocarcinoma. Frequency of some mutations in pulmonary, lung cancers. The above-mentioned mutations have been already validated, FDA approved, as powerful predictive and prognostic biomarkers in the management of diverse solid tumors, such as non-small cell lung cancer, was one of the most aggressive. Gastric cancer, gastrointestinal, stromal tumors, melanoma, breast cancer, and ovarian ones. Moreover, effective cancer-targeted therapies have been developed to target those specific biomarkers. Biomarker-driven targeted therapies immunotherapies, and liquid biopsy techniques like Ascent Trinity have significantly improved patient outcomes while minimizing adverse effects compared to conventional treatments. Despite those advancements, challenges as one of the grand challenges in oncology is tumor intra-tumor heterogeneity. Look, intra-tumor, look the right-hand side. Treatment resistance, high costs, and limited accessibility continue to hinder widespread clinical adoption. In this context, PPO overview in general. As a part of personalized precision medicine aims to tailor therapy by targeting the unique genetic characteristic of a patient tumor, while cancer therapy focuses on activating the human defense resources to control the tumor, not only progression, but induction as well. PPO refers to the study of the tiny details of tumors to find genetic changes that can be targeted with treatments. Potential application for modern technologies in PPO-guided clinical settings include pre- and post-treatment risk stratification and patient selection, molecular response, minimal residual disease MRD, and, for sure, clinical monitoring. The information collected, integrated, and analyzed can help doctors choose better treatment for cancer patients and pre-cancer persons at risk, and decide on who will benefit the most from the treatments pre-selected and obligatory, evidence-based. Meanwhile, cancer is unstable in its genetic makeup and therefore differs from patient to patient. This is why patients with the same type of cancer can have different outcomes and responses to treatment. Therefore, oncologists use biomarkers to provide patients with individualized treatment. Despite those advances, interpreting the clinical implications of a rapidly expanding catalog of genetic mutations remains a grand challenge. That means that the selection of therapies in the presence of multiple mutations requires clinical judgment, supported by quality-centric genomic testing that emphasizes purely actionable mutations. In this context, molecular tumor boards, MTB, can play an increasing role in assimilating genomic data into PPM-guided clinical cancer practice and clinical trials now, thereby refining personalized treatment approaches and improving patient outcomes. Look, please, this is the new multidisciplinary approach I have just already mentioned, MTB. It's just the global illustration. The strong interdisciplinary partnership with MTB enables to tackle clinical unmet needs and lead us to meaningful advances in the highly innovative and rapidly changing field of PPO-guided practice and to improve patient outcomes. Because in both in terms of survival, global survival, and quality of life. Well, an example, you have a cancer diagnosis confirmed, but the standards of treatment, canonical treatment, aren't working for you. What now and then to be done? In this sense, PPO involves analyzing the genetic profile of the cancer patients, pre-cancer persons at risk, or the tumor sample, biosample, to select therapies that are most likely to be effective against that type of cancer at this time point. The PPM-guided approach is also being used to predict cancer risk and to identify people who might be at risk or high risk for cancer and help them lower their risk, to detect cancer early and to diagnose a specific type of cancer correctly and precisely, to prevent its occurrence in high-risk individuals, to choose which treatments and methods are most likely to work, and to evaluate, to assess how well a treatment is working. Cancer treatment has come a long way, but there is still a long road ahead. Despite the strides, researchers, biodesigners, and cancer practitioners have made in understanding the molecular mechanisms that drive tumor growth and immune system evasion, there remain too many unmet needs. For example, modern therapeutic modes and approaches. Targeted cancer therapy. You are much familiar with that. In global and general, cell receptors, small molecules or antibodies as a set of panel of ligands to be pre-selected to get most effective, to be approved by FDA. It's a kind of therapeutic tandem. One just very old example, Herceptin. Receptor, ligand. The other early example, imatinib, very old drugs, practically not used. Erlotinib for EGFR, similar. Since the development of those agents, the advanced genomics technologies has allowed clinicians to rapidly identify targetable molecular alterations with novel drugs that may provide better clinical outcomes than classical cytotoxic chemotherapy. Recent developments in genomics technologies and targeted therapies, including immune checkpoint inhibitors, have dramatically changed the paradigm of cancer treatment by providing durable responses in cancer patients. It's just an example illustrating factors such as high-programmed DAS ligand PDL expression as a very valuable part of targeted immune therapy. Which have been associated with prolonged survival and could potentially be used as biomarkers and target to select patients before initiating specific multi-targeted therapies. Among the newest molecular targets and targeted mechanism of action, I would stress mitotic cycle and DNA repair targeting. Monoclonal antibodies, in particular, engineered chimeric TKR inhibitors, downstream signaling effectors, epigenetic targets, very valuable. It's just an example of melanoma, a combination of 11 targeted, multi-targeted approach for the 2 years with 7 changes of multi-targeted therapies. The outcome. An example of where novel therapeutic approaches have both transformed patient outcomes and challenged the clinical testing in the field of immune oncology, enabled by a better understanding of the complex interaction between malignancy and host immune defense, and aiming at the development of targeted immunotherapeutic cancer drugs. Look, it's just the history, very briefly, the history of cancer immunotherapy. In this context, this kind of therapy is considered as a type of cancer treatment that aims to harness the body's immune system to fight cancer cells more effectively. Look, it's just an example of harnessing the immune system to fight cancer. There are several types of immunotherapy that work in different ways. Checkpoint inhibitors prevent immune responses from being so strong that they harm healthy cells, kind of like brakes on a car. Cancer cells can learn to use those checkpoints to stop the immune system from attacking them. Checkpoint inhibitors block the checkpoints, allowing immune cells to respond to cancer cells. Look, it's just the overview of checkpoint blockade immunotherapy, for sure targeted. Chimeric antigen receptor is a crucial member, is a crucial element of CR-T cell therapy. Just overview, schematically. Cytokine treatments, one of the very, very old, more than 30 years. Look, like signaling the immune systems, cytokine are doing their job. Immunomodulators, also very old. Monoclonal antibodies, rather new, might be 15, 20 years. Newest, personalized cancer vaccines. It's a part not of vaccinology, it's a part of vaccinomics. Omics dictated vaccine development. The latter has become crucial for personalized precision cancer therapy, since the molecular, I have already mentioned about, heterogeneity of cancer and the complex interaction, cancer, tumor microenvironment, and immune cells through simplification of the tumor immune environmental, highly complicated and individualized cancer vaccines, which are adapted at the clinical hospitals. Me personally know only 3 hospitals who are already doing it. Mayo Clinic, MD Anderson, and Cambridge University. So basic component from the manufacturer, individualized adaptation at the laboratory, at the hospital affiliated laboratory. You must understand it's much complicated. Requires sophisticated combinatorial genotyping and phenotypic testing in order to answer a broad scope of important questions of new cancer-related targeted agent discovery, preclinical and clinical development. The co-evolution of tumors and immune compartments, I mean the immune microenvironment, supports the temporal heterogeneity of immune microenvironment, particularly under the pressure of targeted therapeutic approaches. The latter means that therapeutic approaches should account not only for the oncogenic, not only for cancer agent or representative immune checkpoint, but also for the heterogeneity and the responsiveness of the immune microenvironment. Therefore, navigating the spatial-temporal interaction between tumors and immunological compartments of the tumor is critical in informing effective and prolonged responses to targeted immune therapies. Among recent advances in cancer treatment, let me mention some strategic and design-inspired innovations. Look, targeted immunotherapy, CRRT, cell therapy, new cancer gene therapies, using genome editing, including cancer stem cell-driven therapies. Personalized cancer vaccines, I have already mentioned about it. Studying cancer biology and drug resistance is becoming the crucial step in changing the philosophy of making and developing of targeted therapies of the principle in next step generation, including smart cancer therapies. The fight against cancer is witnessing remarkable progress, with innovation in treatment offering renewed hope and better outcomes. From PPM and PPO to revolutionary therapies, the future of oncology is more promising than ever before. In this context, let me mention about the latest innovations. Cellular therapy being based on cancer stem cells. Look, it's just the overview. A small subset of cells in tumors that are characterized of self-renewal and continuous proliferation leading to cancerogenesis, metastasis, recurrence, and maintaining human tumor heterogeneity. Cancer stem cells, now proven to be the key drivers of cancer initiation, I mean induction, progression, and therapy resistance. Therefore, accurate, precise identification of CSCs based on biomarkers can provide a theoretical basis for drug combinations of malignant tumors. Targeted biomarker-based therapies also offer a silver lining for patients with advanced malignancies, and for sure, pre-cancer persons at risk. The latter mean that targeting cancer stem cells through surface biomarkers, signaling pathways and differentiation has now shown promises for cancer treatment. Thus, a rationale for a new treatment strategy is emerging that specifically target the cancer stem cells, which may not only be a small, very percentage of the total tumor mass. Look again the outcome. Conventional cancer therapy, tumor relapse, the outcome. Cancer stem cell therapy in 100% tumor regression. But at this point, in practical sense, not yet solved the problem. Not yet. One more, not FDA approved, but might be a year more. Naprobucacine. It's a new CSC-based targeted drug. Clinical trials, step 2. Might be not 1 year, but not longer than 2 years. Overall, neither generation of the next step generation represents a broad spectrum personalized cancer vaccine approach against both stem cells and bulk tumors that can significantly inhibit post-operative cancer recurrence, post-operative, and metastasis after surgery by targeting both bulk cancer cells and the elusive CSC responsible for relapse, prolonging survival rates. The promise of gene therapy. In terms of cancer therapy, it's a very origin. Gene transfer is an upgraded treatment modality that introduces new genes or modified genes into a cancer cells or the surrounding tissue to cause cell death or slow the growth of the cancer. Recent advances in this area and sub-areas accenting on promoter systems made targeted gene treatments possible. This includes using suicide gene, cancer suppressor genes, gene silencing technologies, and gene editing techniques. Identification of targeted oncogenes and tumor suppressor genes can become the stimulus for rational design of novel selective drugs that execute specific activity directed at underlying genetic alterations. This information can be used to track the progress of cancer and to establish the molecular basis for drug resistance and allow the targeting of the genes or pathways responsible for drug resistance. It's just the overview of gene therapy and its applications in oncology. As I have already mentioned about this small baby with incurable leukemia. The field of cancer preventive, prophylactic manipulations, and thus PPM-based cancer vaccinomics are becoming highly valuable and promising whilst designing a health-specific custom vaccine to help physicians prevent disease, not to treat, to prevent disease or to stop the clinical pre-cancer stage. Personalized cancer vaccination strategy can be a potent approach to trigger a broad-based anti-tumor response that's both beneficial and relevant to individual cancer patients or pre-cancer persons at risk. Look, it's just the overview of personalized cancer vaccines, rather new. It's just details of mRNA vaccines. It's just a separate lecture. Over the past few years, a handful of anti-cancer vaccines have been licensed and pre-approved for use in clinical practice. And with more anti-cancer vaccines currently in development, there is still hope that they can eventually become routine tools used in the treatment and prevention of cancer in the very near future to come. The optimal use of immunotherapeutic agents will hinge on a robust understanding of the mutational profile of a cancer genomes, which significantly dictates anti-tumor immunity and immunotherapeutic response. Very important is combination strategies for cancer immunotherapy. Look, please, here is listed approaches for combination therapy be used. In general. In particular, please look attention at dendritic cells-based combination therapy, very highly clinically efficient. The future prospects of cancer combination therapy are very promising, but it would depend on a rational combination of pathways to be pre-selected, to be included into entities of principally new generation. And finally, smart drug delivery systems, combined with reliable sensor or trackers to help control the release of a treatment based on signals from a person's body, and to secure treatment by precisely controlling how much treatment is given at a time and how often it's given. Please, look, it's just a brief scope of smart drug delivery systems, very briefly. This means the medicine can be more specifically targeted to the affected area or cells and can help reduce side effects and improve the treatment's effectiveness. As a result of the latter, the advancements in targeted therapy and immunotherapy in recent years have led to some of the largest studies in cancer care indicates. Durable clinical responses have been seen in a significant number of patients treated with targeted therapies. As you might see from the above mentioned, personalized and precision medicine, including personalized and precision oncology, it's not a subject for chatting, since it has drastically changed and is keeping on changing the landscape of healthcare. Some comments. London Business School. Individual to be under regular monitoring that helps to detect pathological shifts at subclinical stages. have a high life expectancy and are able-bodied up to 15 years more than those under traditional treatment. This means that the society would save more per person annually. At the community level, the annual savings from each individual may vary from several thousand to several tens of thousands US dollars. In the area of oncology, that means that as little as a 10% reduction in cancer would translate as savings of 4.4 billion US dollars. PPM calls for a transdisciplinary approach. It's one of the most complicated and difficult. And consideration for how best to develop innovation frameworks to support safe and effective deployment of the new enabling diagnostic and therapeutic technologies, not to treat, but to get cured. This approach mentioned should be based on postulates which will change the incarnate culture and mentality. All secrecy, change, and challenge, not in medicine, in the upgraded high-tech culture. The problem that the meaning and philosophy of personalized and precision medicine and oncology is understood by less than 5% of practitioners in the world. In the US, from 2004 through the last year, such practitioners has increased only 2%. At Mayo Clinic, at MD Anderson, at Stanford affiliated hospitals, and UCSF. I have been told by professors from those universities, the rest of American physicians are stupid. I mean, in terms of PPM. Sorry for your patience. Thank you.